Osseointegration can fail due to occlusal overload, bacterial plaque, micromotion during healing, excessive cantilevering, the prosthesis, or all of the above. All of the above. The most common causes of periimplantitis are considered to be plaque and occlusal overload. Excessive cantilevering of an implant-borne prosthesis will result in excessive occlusal force on the implant as well as off-axis loading. Occlusal forces that are within the long axis of the implant are best tolerated by implants. Lateral forces are not as well tolerated and can be harmful if excessive. Lateral forces on implants magnify the amount of stress on the crestal bone surrounding the implant. Off-axis loading of the implant is a term used to describe this situation. Implants that have been judged to be a failure because of infection, bone loss, and or mobility must be removed. If an implant is mobile, it can probably be extracted fairly easily. If an implant needs to be removed but is not mobile, it is still osseointegrated to some degree. Extraction may be possible with effort, or the implant must be removed with a special drill called a Trephine drill. This drill is cylindrical, hollow, open-ended burr design to fit over the implant and cut down the sides of the implant to release the implant from the bone. This may cause a significant amount of bone damage or bone loss, and a bone graft is sometimes placed following removal of the implant. If an implant is judged to be unusable from a prosthetic standpoint, e.g. poor angulation or location, but is not otherwise failing, it may be covered with soft tissue and allowed to remain unused in the bone for an extended time. This is referred to as sleeping the implant. Which of the following is or are necessary for osseointegration to be successful? Which of the following is or are necessary for osseointegration to be successful? Primary stability of the implant, limited micromotion during healing, minimization of surgical trauma, uncontaminated implant surfaces, or all of the above. All of the above. At the completion of surgical placement of an implant, the implant must not be movable in the osteotomy. This condition is termed primary stability of the implant. If the implant is not protected from excessive forces during healing, e.g. occlusion, the implant experiences movement relative to the surrounding bone. If this relative motion or micromotion persists, osseointegration will be prevented. Surgical trauma can prevent the formation of osseointegration by damage to bone cells, often because of excessive heat generated during drilling procedures. Sharp burrs, intermittent drilling pressures, and irrigation for cooling off the burrs and site can prevent or limit this injury to the bone. The limit of heat is 47 degrees Celsius for less than 1 minute. 47 degrees Celsius for less than 1 minute. The implant is sterilized by the manufacturer and protected with packaging to preserve the oxide layer, which is a passivation layer and critical for osseointegration. These conditions must be maintained before the implant is placed into the osteotomy. Site development for implants includes the following techniques. Select all that apply. Guided tissue regeneration, socket grafting, bone grafting with cow bone, bisphosphonate supplementation for bone density. Well, that one doesn't. Orthodontic tooth movement. So I will take off bisphosphonate supplementation for bone density and bone grafting with cow bone. Well, I guess it is. Cow bone is good except bisphosphonate. So bisphosphonates, e.g. alendronate, are used to treat osteoporosis and cancer. Bisphosphonate therapy, especially a history of IV bisphosphonate therapy, is one of the few absolute contraindications for implant placement. Bisphosphonate osteonecrosis of the jaw or bone necrosis, osteonecrosis of the jaw, is a serious complication and is difficult to manage successfully. It can occur following dental surgery, such as extractions and dental implant placement. Guided tissue regeneration techniques have been adapted for bone augmentation in edentulous areas, and the technique has become guided bone regeneration. Several bone graft materials and combinations of these materials are used in the procedure and are often covered with a protective membrane. Bovine bone, processed as a particulate graft material, is commonly used for oral bone grafting applications, including ridge augmentation and maxillary sinus augmentation or sinus lifts. The bovine bone is classified as a xenograft, or bone that is transplanted to the recipient from a member of another species. It can be combined with an autograft or autogenous bone from the recipient patient, or combined with bone from another human being, which is an allograft, or combined with a fabricated bone graft substitute material such as tricalcium phosphate or hydroxyapatite, which are forms of alloplasts. Other site development techniques include orthodontic tooth movement to create space for implants. The tooth movement could include orthodontic extrusion of teeth to bring bone volume occlusally with the tooth and thus increase bone volume at the site of the planned implant placement. Anti-rotational element is added to an implant to prevent rotation of multi-unit restorations. Prevent rotation of an implant, yes. Prevent rotation of an abutment in the implant. Prevent over-torquing of the abutment screw, or all of the above. Yes, it was the abutment, not the implant. I knew that, but well, next time. So the question is prevent rotation of the abutment in the implant. The anti-rotational element is designed to prevent rotation of the abutment and thus prevent loosening of the abutment screw that holds the abutment to the implant. Again, the anti-rotational element is designed to prevent rotation of the abutment and thus prevent loosening of the abutment screw that holds the abutment to the implant. Anti-rotational elements between the implant and the abutment are described as external or internal. The external type consists of a permanent extension from the implant that fits into a receptacle in the abutment. An internal anti-rotational element has the extension as a part of the abutment that fits into a receptacle in the implant. Anti-rotational elements are also added to abutments to prevent the rotation of attached single unit restorations, such as single crown. Again, anti-rotational elements are also added to abutments to prevent the rotation of attached single unit restorations, such as single crown. Multi-unit restorations do not require anti-rotational features to prevent them from rotation on the abutment, since they are connected to two or more implants or abutments, and this give the stability that they need. A radiograph should be exposed and interpreted at which of the following points during implant placement and restoration: at the end of the surgical procedure, following the final torque application to an abutment, anytime the fit or seating of a component must be verified, or intraoperatively to verify implant position, or all of the above, obviously. Radiographic verification that the desired anatomic placement of the implant or implants has been achieved is desirable at the completion of the surgery to make sure the implant and any vital structures nearby are separated as planned. Also, positioning of the implant from a prosthetic standpoint can be stressed and corrections made at this time if necessary. In addition, the surgeon should have documentation of the successful implant placement before the patient is dismissed. The surgical placement radiograph is an important baseline record that will be used for comparison at multiple time points during the life of the implant. During the surgical procedure in which the implants are placed, radiographs can be taken or depth gauges, the drills, the implant itself, or other markers to judge whether the proper depth or anatomic location has been achieved before further drilling or implant advancement is accomplished. After the final torque is applied to a long-term healing abutment, an impression coping or a post, or the final restoration, verification of the proper mating of the components is necessary. Impressions for fabrication of prostheses and the subsequent laboratory procedures that rely on the impressions cannot be accomplished accurately if any of the components are not joined together completely, also referred to as being down. Inaccuracy during the fabrication of a restoration will prevent the prosthesis from fitting passively to all the implants involved. This non-passive fit can lead to implant failures. The hole that is surgically created in the bone to receive the implant body is called osteotomy, bone channel, smokestack, callus core, or chimney. Answer is osteotomy. The osteotomy is prepared with precision to make it prescribed size that is appropriate for an implant being used. If the osteotomy is too small, either in width or length, the implant may not go to depth or seat completely to the desired level in the bone. The overall implant shape, which is a macrostructure, and the bone quality at any site dictate how the osteotomy must be prepared. If the bone is very dense and the screw-shaped implant is being used, the osteotomy may be tapered, meaning that screw threads are created on the walls of the osteotomy to receive the screw threads on the implant. A drill designed as a thread tap is used for this purpose. Many implants are designed to be self-tapping, meaning the tapping of the bone as a separate step is not necessary because the threads of the implant are designed to engage the bone and guide the implant forward. If the osteotomy is too large for the implant diameter, or if the osteotomy is over-prepared or poorly prepared, the implant will lack primary stability and an unacceptable result that will cause osteointegration to fail. The most common source of patient dissatisfaction with implants is pain, appearance, mobility, or loss of osseointegration. I think it's appearance. Yes, appearance. Implants have bone very predictable, have become, very predictable and successful from a functional standpoint, and failure of implants due to loss of osseointegration is not common. Satisfying patient expectations of aesthetic outcomes is a most difficult aspect of implant treatment, since restoration of bone, gingival contours, and papillae is sometimes not possible. Absence of papilla, a papilla between adjacent implants, is a common problem, and for this reason, it may be advantageous to avoid placing adjacent implants if possible. Note, black triangle disease refers to an absence of one or more papillae, which creates an aesthetic concern. Which of the following was or were included in the 1986 Albrechtson et al. Criteria for functional implant success? Which of the following was or were included in the criteria of implant success? Implant is immobile and has no peri-implant radiolucency. Bone loss is less than 0.02 millimeter a year after the first year of service. No, I don't think so. Absence of persistent and or irreversible pain, infection, paresthesia, or violation of the mandibular canal. Success rates of at least 85% at year 5 and 80% at year 10. I will say all of the above. Yes. It sounded pretty obvious. I didn't know the answer, but this set of criteria is often quoted to help define or determine whether or not an implant is successful. Implant mobility indicates loss of osseointegration and implant failure. Failure. Implants with only partial loss of osseointegration will still be stable. Again, implant mobility indicates loss of osseointegration and implant failure. Implants with only partial loss of osseointegration will still be stable. A peri-implant radiolucency indicates that bone is not in contact with the implant, and it suggests loss of osseointegration. A peri-implantal radiolucency often has the appearance of a distinct widened periodontal ligament of a natural tooth. Persistent pain, infection, or paresthesia are not normal implant outcomes and indicate definite complications of implant placement. A radiographic appearance of violation of the mandibular canal by an implant could be misleading and would not by itself define failure. Radiographic configuration of the implant malposition, particularly in combination with persistent pain, infection, or paresthesia, would mean failure. Success rates are generally higher than 80 to 85%, today with 95% and higher being expected. direct structural and functional connection between ordered living bone and the surface of a load carrying implant is the definition of, again, direct structural and functional connection between ordered living bone and the surface of a loaded carrying implant is the definition of a cold weld ankylosis, osseointegration, metal callus formation. Which one is the direct structural and functional connection between ordered living bone and the surface of a load carrying implant? Osseointegration. Osseointegration means direct bone to implant contact with no intervening periodontal ligament or any other tissue. There is no insertion of connective tissue fibers into titanium, meaning there cannot be a functional there cannot be there is no insertion of connective tissue fibers into titanium, meaning there cannot be a functional periodontal ligament. Connective tissue presence around the implant means failure of osseointegration and implant failure. Epithelium does attach to titanium via a junctional epithelium structure called hemidesmosomes and basal lamina. Titanium is usually covered by an oxide that is biologically inert and prevents host tissue access directly to titanium itself and allows osseointegration. At the light microscopy level, there is an intimate association of bone to the titanium. Within a few weeks of placement of the implant, woven bone is laid down on the bone-implant interface. Woven bone is characterized by a very random orientation of its collagen fibers, and it is the first bone to be established in the implant. Within a few more weeks, the woven bone becomes lamellar bone. The conversion of lamellar bone is thought to be encouraged by the presence of functional forces placed on the implant to stimulate the bone. Roughened implant surfaces, such as those created by sandblasting and acid etching, etc., encourage the accelerate the bone formation and the titanium at the titanium surface. Implants should not be planned in young individuals until skeletal growth has been completed. True. Implants should not be treatment planned in young individuals until skeletal growth has been completed. That is correct. Implants are essentially ankylosed structures and do not erupt or move physiologically within bone. Implants are essentially ankylosed structures and do not erupt or move physiologically within bones. If the growth of the individual has not been completed, the original positioning of the implant in the jaws may become increasingly unfavorable due to changed shape or size of the surrounding tissues. Early successful aesthetic outcomes can be lost. The implant may also prevent normal development of the jaws. In this is question 151. So this does not go with the implant questions, so we will leave this for later. Yeah, we'll leave this for later because we're talking about implants right now. So let's do video 2.